Okay, so the first things that we're going to be doing here, let me stop the video, is go over some of the diagnostic procedures that go along with the chest. So the first one, and again, I'll open up the PowerPoint, so I'm going to go through these diagnostics a little quicker here on the first few pages because they could be done as an independent piece. And then when we get to actual problems, then I will slow down just a little bit. But these basic things here we'll talk about. You can write the stuff down when you open up the PowerPoint after your exam tomorrow. So the bronchoscope is done to inspect the larynx, the bronchi, the trachea, and it's all done via a scope that they put down through the trachea. What do we use it for? Well, they can use it to examine tissue. They can use it to take biopsies of tissue. They can use it to identify areas that may be bleeding.
No, please.
And you're able then to determine. Don't forget to mute yourselves, okay?
Sorry.
That's okay. It's easy enough to forget. And then what do we do? Well, here's an actual picture showing the bronchoscope. So some of you have seen these at Ashland. Dr. Young is very good about inviting students in to see a bronchoscope, and that's pretty much they bring in a cart that has the monitor on it and houses the scope. And then you are able to actually visually see on the screen, and he's good about explaining what's going on. Oftentimes they're doing it to do bronchial washing so that they can get mucus out of the lungs, etc. Or they can take biopsies from it also. But this is pretty much what it looks like from a patient's perspective, and then what it looks like up on the screen. They are given a sedative medication because you can imagine you would not tolerate this tube being passed down into the throat area without having some type of sedation or some type of throat spray, especially if you were conscious and fairly with it. Medications, it does require a consent for letter B, and they need to be NPO about 6 to 8 hours prior. That's so that there is no issue with vomiting or aspirating if that would occur. Medications, sometimes you'll see them give atropine, that does dry secretions up. Sedatives such as fentanyl or Versed, they like to give Demerol sometimes, is a good one that they utilize for these conscious sedation medications. Fentanyl, if they're not allergic to it, seems to be kind of a drug of choice because it acts very quickly, but it also dissipates fairly quickly for them too. And then we talked about a little bit of medication to numb or decrease the gag reflex. So there's viscous lidocaine, there's Cetacane, which is a spray that they can spray at the back of the throat. So you have a couple options for that. Post-procedure, you kind of have this written out. A semi-Fowler position, especially if they're conscious, allow the saliva to drool just a little bit, or you can give them a suction or suction their mouth out. That's probably going to last somewhere between 20 minutes to a half hour, the numbness at the back of their throat, and then it should start to dissipate. We'll start out with giving a little bit of water or maybe a few ice chips, making sure that they can swallow okay. Because they've had conscious sedation, we do vital signs every 15 minutes until they're at a pre-procedure drinking, urinating, ambulating, vital signs, etc. Okay? And once they've met that goal, it usually takes about an hour or so 4 sets of vital signs, and then they can either return to their room, or you can stop doing the frequent vital signs, or they can be discharged and somebody can drive them home. Things that we would be watching for might be some irrational behavior due to them not tolerating the meds very well. Again, if they're outpatient, they shouldn't be left alone. They should have somebody check on them for about a 24-hour period. Some of the complications that can occur from having this might be a pneumothorax, so we would watch for breathing difficulties, any changes with possibly bleeding or expectorating large amounts of blood, and we'll watch for vital sign changes. The most common complaint after some type of scoping procedure might be a little bit of sore throat, just from the scope rubbing at the back of the throat. And they can use warm fluids, hot teas, something like that, or lozenges can also help. Our next procedure then is a mediastinoscopy. The purpose of it is to detect some type of lung metastasis and to explore and biopsy mediastinal lymph nodes. For description of the procedure, this is what it looks like. So the mediastinal scope is a little smaller than the bronchoscope, and they're actually going to make a incision in the suprasternal notch here. So just at the midpoint almost of the trachea, they insert the scope, and then you can see here where they're able to look and view at the mediastinal lymph nodes and also take biopsies of them. There's more of a little close-up. They allow for visualization and biopsy. We said that incision is made at that suprasternal notch under a general anesthetic, so they go to the OR for this. And they take that lymph node, and then you'll send that to lab, and then we'll hear back in a couple of days as to what the results are. The reason for a mediastinoscopy would be that if your CT scans or your MRIs or something highlight abnormal lymph nodes in the mediastinal area, we can do a biopsy of those, and this is really the only way that we can reach them. And one of the things going is if the mediastinal lymph nodes are positive, it kind of will reflect what type of treatment we can do for your particular type of lung cancer. Oftentimes when those mediastinal lymph nodes are involved, it's a little more advanced case of lung cancer. So it will kind of dictate how the surgeon or the oncologist is going to approach the patient on treatments. Our third type of diagnostic test would be a thoracentesis. You can see that there's four reasons why we might do this. One would be to remove air or fluid from the pleural space, diagnostic aspiration of pleuritic fluid, pleural biopsy, meaning we can take a sample of lung tissue from this, or we can instill some type of medication. And we'll talk about that more in depth in a little bit. What do we do to prepare the patient? Well, again, it's an invasive procedure, so we would have to have a consent. You would have to do your timeout procedure at the bedside or wherever they're going to do this, maybe down in fluoroscopy. We would give a local anesthetic. We would not, but the physician would insert some type of lidocaine topically into the subcu tissues to be able to tolerate having the needle inserted. Our responsibility would be to keep the patient immobile, more of an orthopnic position sometimes for these procedures is the best. So they might elevate the arms up onto a bedside table, have them semi lean over, and then they would access the rib cage, oftentimes via the back area. The patient at this point, if we've given a few minutes for the lidocaine to work, should feel pressure at the puncture site, but really should not have a lot of major pain. And then once the procedure is done, really should have no discomfort post-procedure. What are some complications then that could occur? Well, we could have some type of infection. Again, it's an invasive procedure. We could have a pneumothorax. Maybe the needle punctured the lung and it made a hole large enough for it to collapse. Or we could have pulmonary edema. Documentation: the specimen needs to be labeled and sent to lab. The amount and the nature of the fluid that is removed. The site, what it looks like. You put a Band-Aid to the site, or you put a 2x2 with an op site, however you covered the hole. Lung sounds before and after the procedure, and their toleration. Another thing that will often happen, and I don't know that I have, yes. Okay, so an occlusive dressing, let me move back there. Let me put that up for a couple more minutes. Okay. Then post-procedure, an occlusive dressing over it. They probably should stay fairly immobile for a while. The puncture site should be up for an hour. So if I had the right side was the side that got drained, I would want to lay on my left side with that right side up for a while. Then vital signs every 15 minutes, just watching for any type of respiratory distress. And then the other thing that they will do is a chest x-ray post aspiration, just to make sure that we didn't cause a pneumothorax from the procedure itself. Okay, another type of procedure that they could do would be a lung scan, or they can call it a VQ scan. And the purpose of this would be to check for blood flow. So the perfusion scan is to check for blood flow with an injected radioactive dye. The area that does not take up the dye would be the areas that you would have poor perfusion to, meaning there's not good blood flow. Ventilation scan is done after the perfusion, or oftentimes together. They deep breathe oxygen and radioactive gas, and then they scan the patient. Again, the red is a match or a mismatch. Those areas where that radioactive gas does not get to tells you that there's poor perfusion to the area, poor ventilation to the area. They are primarily done for those people that have a suspected pulmonary embolism. And our last type of procedure that we can have done might be a lung biopsy. This is done to study lung tissue. There are 3 ways that we can get our biopsy. The first one is a transbronchial biopsy. The second is a percutaneous needle biopsy. And the third is a transbronchial lung biopsy. Again, the transbronchial biopsy is done via the bronchoscope. The percutaneous needle biopsy is often done in radiology with fluoroscopy. We would take it to the area that the mass was, or the suspected tumor, and they could biopsy that. And then the transbronchial lung biopsy, again, would be done via a bronchoscope. Complications, possibly a pneumothorax would make sense to you, that we could possibly cause some type of puncture. Hemorrhage, again, you're taking biopsies of tissue that you're really not quite sure what it is. Some tumors are very friable, meaning they collapse or they bleed very easily. We could have empyema, again, infection within the lung itself, or we could have an air embolism. Post-procedure care, is pretty much the same as either doing a thoracentesis or a bronchoscopy. So depending upon which route they took, these samples would be how you would recover them in the post-op period. Okay. Different problems that the patient might have related to the lung that would cause them to have some type of thoracic surgery. The first one would be a lung abscess. This is a localized pus-containing lesion within the lung. Folks that are high risk for this would be people that have impaired cough reflexes, altered consciousness, maybe they've had a stroke, some type of seizure activity, maybe they suffer from alcoholism, maybe they have a nasogastric tube, or possibly dental caries. What, for the things that I have listed on the screen, what do those people all have in common? What is their one major risk? Is anybody able to tell me?
Is it fluid and electrolyte imbalance?
They could have that, but give me something else that something could happen to all of these same people. A risk.
Aspiration.
What was it?
Aspiration.
Yes, aspiration. Thank you, whoever said that. That's great. So they're all at a high risk for aspiration. So they've aspirated some type of fluid, even a piece of corn, whatever it may be. And then that particular substance has caused this infection or abscess to occur. Signs and symptoms. Patients might have fever, a productive cough with a foul-smelling breath, some type of pleurisy, which is just a dull chest pain, dyspnea, weakness, weight loss, and anorexia. So this is what the picture looks like. You can see that it's just a graphic showing you that there's some type of infection within the lung itself. So we call it an abscess. If that abscess here breaks open and travels to the pleural cavity, then we can have what we call empyema, and that's going to be one of our problems that we talk about. But if that abscess breaks open and it flows into the pleural cavity, we call it empyema. The focus of the treatment for these particular patients is antibiotic therapy. So they're usually on antibiotics for 6 to 12 weeks. So this might be somebody that has home care or comes into an infusion center and has multiple weeks of infusions of IVs through a PICC line or something like that. Nursing care related to this, a diet that's high in protein and calories. Again, we said they're a little anorexic, they've had weight loss, they overall just do not feel good, so they have been eating poorly. So we want to make sure that they're able to, when they do eat, it's very productive. So protein so that they can heal, and calories so that they can maintain or gain weight. Emotional support, it is a long episode of this, so it's not something that's going to resolve itself quickly. Coughing and deep breathing. Coughing and deep breathing is very important. It helps pop open those alveoli. It does help with oxygenation. And the biggest problem that we have for these folks is compliance, and that is the focus of the need for the antibiotics. Maybe after 6 weeks they start to feel better, but their infection is not completely gone. So we need to make sure that they complete the course of antibiotic therapy that the doctor has prescribed. The next piece that your notes talk about is good mouth care. Remember, we said they have a foul smelling breath, so you can imagine their oral mucosa. It just doesn't taste very good, so food might not even be very palatable to them. So using some type of hydrogen peroxide, a Paradex type mouthwash, may help clean the mouth and make food more palatable for them. Okay, our next problem that we could require surgery for might be some type of pleural effusion. This is just fluid in the pleural space, secondary to some other problem. If you remember back to your anatomy and physiology, you do have normal pleuritic fluid all the time that is produced, small amounts, it is reabsorbed. So there's always a little bit in there to prevent friction between the parietal and the visceral linings so that the lungs can inflate and deflate without any problems. But in this case, we're either producing more pleuritic fluid or we have some type of absorption problem where we're not absorbing the proper amount of pleuritic fluid that we should in a 24-hour period. And you can see here's the buildup of the pleuritic fluid. So it does mimic a collapsed lung because this lung would be their right lung cannot fully expand. So we have two types of fluid that can cause us problems. One is a transudate. This is just the normal production of pleuritic fluid, but there's an absorption problem. So the fluid is not being reabsorbed at the proper rate, and that could be due to some type of congestive heart failure, so their circulatory system is altered, or it could be from like a severe MI. Exudate is another type of problem that would be a byproduct from bacteria or some type of tumor. So when they take the pleuritic fluid and they've aspirated that like on a thoracentesis and they take the fluid to radiology, it will come back and tell them if it's a transudate, meaning it's just normal pleuritic fluid, or it's an exudate, meaning it is a byproduct of some type of infection or some type of tumor. And then that lets the physician know the course of action that they're going to need to take to try to remedy the situation. Signs and symptoms of a pleural effusion will be shortness of breath. If we were percussing, which oftentimes associate degree nurses or even baccalaureate nurses really do not percuss, but if you go on to be an NP or a critical care nurse, something like that, percussion might be part of your repertoire. We do listen to lung sounds, so they would be absent over the areas that are contained with fluid. And you could see that with this particular picture. If you look at that lower area, there's not going to be any gas exchange taking place or any air movement. So if you were listening down into the bases of that right side, it's going to be absent of lung sounds. Treatment for these folks will be a thoracentesis. They can be performed when there's a large area of pleural effusion. If it's fairly small, they may or may not do it. So it just depends on the amount and how the patient's being affected by it. If it continues, they can do a pleurodesis, meaning that draining the fluid and trying to correct the problem is not working. So they may need to do a pleurodesis. A pleurodesis is instilling a type of sclerosing agent, and they tend to use sterile talc or doxycycline. What they do is put it in either a thoracentesis needle or they can put it in via a chest tube. The sclerosing agent is dispersed in the between the visceral and the parietal linings. It actually obliterates that space. It fuses those two linings together. It kind of shuts off the hole so that you can't get an accumulation of fluid. Kind of a last ditch effort for folks. So it isn't something we would jump to right away. But if we wanted to do some type of palliative treatment, something so that they could manage at home and not have to keep coming back into the hospital, we could do something like that. How are the patients positioned when they have a pleurodesis done? Well, we put them in various positions to help distribute the medication that is there. Okay. And that would be up to us. So the physician would instill the sclerosing agent. We would probably also need to give some type of pain medication for them to tolerate that because they have a sense of a burning sensation within their chest. And then it's up for us to distribute that. Okay, our next problem is empyema. And I said we would talk about that in a little bit. So it's accumulation of pleuritic fluid in the pleural space. So here's what a lung abscess would look like. Here's what pus in the pleural space looks like. It may start out a little serous and then progress to purulent to copious amounts. If it involves the entire cavity, it could impede lung expansion, meaning it could be just like a pleural effusion, only instead of it being pleuritic fluid, it's actually infectious fluid that is accumulating. One of the other issues that can occur when you have a empyema, if we don't continue to have the patient confident and deep breathe, you have this in B in your notes there, they can develop a fibrothorax. It's a fibrous membrane that encapsulates the lungs and will impede how well they can expand. That in itself is going to be a surgical procedure to remove that fibrous membrane. I think the analogy that I can use for this is that if you've peeled an orange or a grapefruit or something and you still have that little fibrous white membrane on it, that's kind of what it reminds me of around your lungs. So until that all gets peeled off, the lungs can't completely expand very well. Treatment then for an empyema will be prolonged antibiotic therapy, drainage of fluid through a thoracentesis, chest tube, or even a thoracotomy where they go in and make a surgical incision and actually clean the chest out. And then we said coughing and deep breathing. Coughing and deep breathing will prevent that fibrothorax. Then if by some chance that fibrous peel has developed, we call it a decortication. That's doing a thoracotomy and then going in and the surgeon actually has to peel that off in order to free up that lung. In order for it to fully expand, that fibrous membrane has to come off. Okay, our next grouping then are tumors of the lung. And these are the leading causes of cancer in both men and women. 80% result from smoking. There's a lot of literature anymore on secondhand smoke. You do see the gentleman, the commercial on TV for smoking cessation. He comes on and talks about he never smoked a day in his life. I think he's like 54 or something for his age, and he relates it all to secondhand smoke. So very high correlation between a lot of our chronic lung problems these days and exposure to smoke. So, even if you smoke in your home, remember, or you smoke yourself or a family member does or a grandparent, always ask them to step out of the home to smoke so that your children and stuff are not exposed to it. 10 times more likely to have some type of tumor in the lung than non-smokers, although we will talk about cancers that are related to other things other than smoke inhalation. 85% of lung cancers are fairly well advanced by the time they are diagnosed because they're a fairly silent cancer in themselves. I shouldn't say most anymore, but if they're found late, whether while they are well advanced, oftentimes they have a fairly poor prognosis, especially if they're advanced to other areas like lymphatic areas. If they're contained within a lobe and can have surgical removal, then oftentimes their success rate is pretty good. But if it's well involved, mediastinal lymph nodes, etc., usually their prognosis is oftentimes less than a year. So we kind of talked about this. Smoking, I have added within your notes, secondhand smoke. Those are the biggest culprits. Inhaled carcinogens, based on where you've worked, we see a lot about asbestos, mesothelioma, etc. Those kind of things are all related to exposure, either through your job, military, those kind of things. Hereditary, just poor gene pool predisposition. Can't really change that. Pre-existing chronic pulmonary conditions can also pre-expose you to lung cancers. And that one I don't think I have in your notes, so you can add that one. Pathophysiology, 90% of them develop within the bronchial tree. Just over time, and this can be years for these to develop, the changes with the cells keep continuing and they become more atypical, more immature cells, etc. The first develops as a carcinoma in situ, so most of them are fairly slow growing, but unfortunately most secondhand smoke folks or primary smokers or people that are exposed to their workplace are not getting routine chest x-rays every 6 months to every year to catch something fairly early in life. They come into the doctor's office or the ER because they have pneumonia, bronchitis or something, and they do an x-ray and it shows that their tumor is there. Small cell carcinomas are very fast growing. These are folks that have one of the poorer prognosis. Most lung cancers are primary tumors and then they metastasize elsewhere. And I think you have that all in your notes there. So these are some of our types of cancers lung cancers. One is squamous cell carcinoma, almost always associated with cigarettes, could be some environmental exposure also. It accounts for 30 to 32 of our lung cancers, and they metastasize by direct extension. They just grow into other areas of the tissue, and our best therapy would be surgical resection. Adenocarcinomas, these are really not related to cigarette smoking at all. 20 to 40% they account for. They metastasize to the peripheral lung area and they metastasize via the lymph and the blood system to other parts of the body. Again, surgical resection is our best treatment for this. Our third type is large cell. These are cigarette smoking and again, exposure to other environmental carcinogens. They account for 10 to 15%. They're highly metastatic and they go via the blood and lymphatic, usually the central nervous system. So oftentimes they will develop some type of brain tumor associated with that. And this is a surgical resection also. Our last type is small lung cell cancers. And these include oat cell. And we'll talk about oat cell when we get to our pituitary issues. But again, cigarettes and carcinogens, 20 to 25%. This is the most malignant form, and it is associated with other endocrine disturbances like SIADH. They have the poorest prognosis, usually less than a year. These are some of your oral medications that you see advertised out on your TV programs and those kind of things about taking oral treatments for lung cancers. And those are usually more related to small cell because it is highly aggressive. So we do have some alternatives and we're making some headway, but the best thing you can do, although you won't fully deter your exposure out in the environment, non-smoking is probably the best way we can prevent a lot of these. So what are some of our signs and symptoms? Well, unfortunately, a lot of the signs and symptoms do appear late, so it's a fairly silent disease. That's why sometimes they don't get a very good prognosis when they are diagnosed. So some of the symptoms, a cough that is persistent or it has changed. If you've been a smoker for 25 years, chances are good you have a dry, hacky cough. You also have a change in your voice. But if something changes from that, we probably should see the physician and get that checked out. Respiratory problems, if you haven't had a recent bronchitis or cold and you're coughing up blood, hemoptysis, again, you should see the physician right away. Some type of unexplained pleural effusion, again, could mean that you have some type of lung cancer or tumor causing that. Signs and symptoms of cancer in general, weight loss, anorexia, and then some type of unexplained anemia. So you didn't just have surgery, you don't have an iron deficiency, anything like that that could be causing it. Again, oftentimes those are related to some type of malignancy. Ectopic hormone syndromes, these are lung cancers that are related to small cell types, and they present in the doctor's office because they're a 55-year-old that has developed facial acne. Maybe they have connective tissue issues. They believe there's something wrong with the joints, etc. So they'll work them up for all of these other things, which in turn, their small cell lung cancer is actually causing these changes within their body. It can delay a true diagnosis and delay treatment for the true problem that they're actually having. So just keep that in mind. Again, we'll talk about pituitary here and we'll touch on that again, but that is one of the downfalls of having small cell is it often presents itself as something else, and then they go to the physician's office due to these other problems, and nobody really looks for the small cell cancer itself. Diagnostic wise, we know the only definitive way you can tell somebody has cancer is to do a cell examination. Although x-rays do show that there is something there, we really can't definitively say what it is until the diagnostic cell exam has been done. Is it primary or secondary? The staging, tumor node metastasis classification system, the higher the numbers represent later stages, less chance for a cure or long-term survival. So the higher the numbers are, and they oftentimes just go up to about stage 4, but the higher the numbers are on each of those, the poorer the prognosis. And I think you had that when you went over a general cancer in your 1010 or your 1125 materials, or 1050, I should say, is probably where you did it. Treatment, surgery is really the only cure if it is resectable. Again, if you have mediastinal involvement and it's throughout, it's probably going to be some type of palliative type treatment to try to keep it under control. Radiation is daily, oftentimes 5 to 6 weeks worth. It's palliative or adjunctive type therapy. Small cell is highly responsive to radiation, but once you stop it, it tends to come back fairly quickly. Complications of radiation therapy, you have on your paper there esophagitis, pneumonitis. You can have fibrosis of the lung tissue due from repeated radiation. Chemotherapy, primary therapy for small cells, palliative and adjunctive for non-small cells, focuses on administration, side effects, and quality of life. Again, you kind of have to make that determination on your own. If the treatment is going to prolong your life by quite a bit, why not try the treatment? If it's going to give you an extra month, do you want to be sick versus just living with what you have and feeling as good as you can for as long as you can? And then the last one are complementary and alternative therapies. Again, your book talks about those in many of the different disease processes, acupunctures, aromatherapy, any of those things can be complementary and alternative therapies to this. And again, I think you have to have a buy-in to these CMAs. And if you do, oftentimes they are very helpful for folks, at least for symptom management. Okay. The next groupings are chest traumas, where you might need to have some type of surgery related to that. Chest traumas are critical injuries. Again, airway impairment for chest injuries is the leading cause of death, and dysrhythmias then is the second. Hypoxemia, some type of disruption of your airway, some type of injury to the lung itself, maybe to the rib cage, maybe to the respiratory muscles, collapsed lung, that could impair how well you're able to exchange air. Hypovolemia might be some type of rupture of a great vessel, again, causing massive blood loss, which would impede how well you can oxygenate. And then our third one would be cardiac failure. This might be some type of damage to the heart muscle itself, cardiac tamponade, a bruising to the heart, or a high intrathoracic pressure can impede how well the lung can expand, or the heart, excuse me. So our assessment, our top priorities for a chest trauma are A, B, C, C plus C. So our A is what? What are we assessing to make sure what is open?
Airway.
Airway. And then B would be what? Make sure they're doing this.
Breathing.
Breathing. And then how about the first C?
Circulation.
Circulation. Then we get down to the next ones because they've been some type of trauma. Do you know what another C might be? Cervical spine. So everybody's going to get a C color, right? If we think they've had some type of neck injury. And then the other one would be consciousness. Are they conscious, or did they lose consciousness with their particular accident? That would clue us into any type of head injury that might go along with this. They've arrived at the ED, like that little sound there. So here they're going to get x-rays, blood work, oxygen therapy, EKGs, CAT scans, making sure that we have no internal injuries, cervical spine x-rays to make sure that we have no injury to the cervical spine so we can remove their C-collar. Oxygenation, airway. If airway is not enough, they might need to be put on a ventilator for resuscitation of the airway. Restoring fluid volume, crystalloids, colloids, maybe blood products, plasma, fluid expanders, something, especially if they're having blood loss. If they have some type of chest wound, sealing the chest, if there's an opening there, some type of drain, draining the peritoneal cavity, draining the pleural cavity, because we said that those things can actually impede how well the lung is expanding. Injuries that include both pulmonary and cardiac contusions, maybe rupture of the aorta, tracheobronchial tree damage, esophagus, diaphragm, cardiac tamponade. All of those things are critical injuries, and that's why oftentimes some of our massive injuries, motor vehicle accidents, etc., are dead on arrival, or they don't make it past the accident site because something major has happened within the body that's caused probably a sudden death. Okay, our first trauma that we're going to talk about are fractured ribs. So it is the most common injury of the chest, and the danger that we have when we fracture a rib is some type of puncture to something inside the chest wall. So fractures 1 through 3 are fairly unusual because they're fairly high up. You have the clavicles that kind of help protect a little bit. But underneath that are the subclavian. So if you rupture or fracture one of those ribs, the area that it could puncture would be the subclavian. Fractures 5 through 9 are the most common. Fractures 12 through 10 are a little lower, and when we fracture those, the risk is a laceration of the liver or spleen. The focus for our patient with a rib fracture would be pain and then preventing any type of respiratory complication. So we want just enough pain medications that they can still cough and deep breathe for us so that they don't get pneumonia, etc. But we don't want enough that it actually suppresses their ability to do that. It'll take about 3 to 6 weeks for those to heal. And we really do not want to bind the chest. Sometimes they'll do an elastic girdle kind of thing so it can expand with the chest, but you don't want to take an ACE wrap or something and bind. It feels good to the patient that you can expand your chest, but you put yourself at high risk for pneumonia and circulatory issues when you don't allow the chest to expand. We'll do flail chest here, a little bit of it, and then I'll let you take a 10-minute break. So flail chest, this is one of the most critical injuries that can occur to the chest. Again, a lot of motor vehicle accident patients die due to a flail chest. The definition is that you have ribs that are free floating and cause a paradoxical movement. It would be to some type of blunt trauma or crushing blow to the chest. And they have a paradoxical movement. The injured portion moves opposite of what it normally should. So it pulls in with inspiration and pushes out with expiration. If you have a small flail chest, you may not even be able to notice it unless they do a chest x-ray, which they probably will. You're probably not even going to know that you have a flail chest. You may just assume that you have just a basic fractured rib. So this is what the flail chest looks like. So I'm inhaling, and when you inhale, the lungs should puff out, but instead on a flail chest, it sucks inward. Then on expiration, the lung should deflate, but instead the lung puffs outward. They kind of have a pendulatory ventilation exchange, meaning it's very stagnant. There's really no gas or air exchange taking place in the area of the flail chest. These patients can develop respiratory acidosis from this type of movement. They can have a mediastinal flutter, which means that the mediastinum can shift back and forth, and they can have cardiopulmonary embarrassment, which just means that they have a low cardiac output when this is happening, especially if it's a large flail chest. Coughing for them is impossible. It results in accumulation of secretions, possibly pneumonias, atelectasis. If you've had enough blunt trauma to cause a flail chest, oftentimes there are other internal injuries that are also occurring. So it complicates those other injuries. While I have a little bit of space here, let me draw you a picture. Let's do. So here's my sternum, and we have our ribs coming off. Okay, so here's a rib, here's a rib, here's a rib. All right, so other thing, same side. Here's our rib. Here's our rib. Here's our rib. So on a typical fracture, we would only have one fracture, meaning it would be broke here only. So in this case, the rib that remains is either attached to the sternum or it's attached to the spine. In a flail chest, we have a fracture on two sides of the ribs. This is the area that is what we call free floating. Now these pieces aren't floating over here or anything like that. They stay put, but they're not supported by either the sternum nor the spine. And that's what makes a flail chest versus a rib fracture. Okay, so that's the difference between the two. In a flail chest, you have a free floating section of ribs. And the more ribs you have fractured, the worse the flail chest is. So you can see if you only had one, you probably wouldn't even notice it. But if you get 2, 3, 4, then you're definitely going to notice the flail chest. Okay. Get rid of this. Treatment. Mechanical ventilation with PEEP. Why do we put them on that? Well, it does correct the acidosis that has developed. It stabilizes the chest wall. And that stabilization should return in 5 to 10 days. If you can remember back to that very first week's lecture, clear back in January, when we talked about PEEP, we talked about PEEP leaving some type of residual of air, right? It left the lungs slightly puffed at all times. So if you put them on PEEP and the lungs are slightly puffed at all times, it does give stabilization to that chest wall without surgically going in there and doing that. Secondly, they're going to need analgesics to control their pain because these people will not really even be able to cough and deep breathe for you. They're in so much discomfort. If by some chance we have to go in and do a thoracotomy due to some other surgical problem internally, we will fixate the fractures with either sutures or wires. Now, that doesn't mean that you might not end up on a ventilator just due to the criticality of your injuries, but we would not solely put you on the ventilator for your flail chest because we've already fixed it by wiring them shut or wiring them together. And then D, we want to avoid fluid overload. Remember, we probably had a contusion to the lungs. When you have a contusion or some type of injury to the area, it swells, it brings fluid to the area to start that inflammatory response. So we're going to need diuretics to get that extra fluid off. And we may need albumin to keep the fluid within that vascular space. Okay, so that's our two medications. Diuretics to pull some of that fluid off, and albumin to keep some of that fluid in its proper spot. And after you get that written down, go ahead and take a 10-minute break and come back at 11:05, please. Okay, we'll go ahead and continue on then. The next problem that you could have with the lung would be a pneumothorax. This would be a complete or partial collapse due to either air in the lung or you've had some type of puncture or something that's caused it. So the first type is a closed pneumothorax. This would be no external chest wound. Air is leaking into the pleural space and the lung collapses. Could be by, several reasons. Injuries such as a fractured rib, some type of blood trauma can actually cause the lung to burst. Puncture during maybe a subclavian catheter insertion, or remember we talked about barotraumas with the ventilator. They can also be spontaneous. Folks that have COPDs or chronic lung problems tend to have blebs or some irregularity on the lining of the lungs. Those areas can weaken and they can actually burst and cause a collapse. Also, there are some folks that if you're playing games that cause a lot of high chest pressure, football, those kind of things, they can cause a spontaneous pneumothorax. Also, there is a profile that fits some of our folks. If you're male, very tall and thin, those people seem to be at a high risk for spontaneous pneumothorax. So we've had several AU students. One was a basketball player that came in a couple years ago with spontaneous pneumothorax. He was like 6'3" and maybe 180 pounds or something, and so tall and thin, and it just happened for no reason. So there is a little bit of a profile to that. Signs and symptoms. They can have respiratory distress, increased heart rate, complaint of chest discomfort, decreased breath sounds, cyanosis, and shock can develop. This would be for a very large pneumothorax that was already causing us severe problems. There are some pneumothoraxes that are fairly small, less than 20%. They won't even do anything with them. They'll just watch and monitor them and have the patient kind of take it easy for several weeks to make sure that it doesn't advance. A larger pneumothorax will require some type of probably oxygen therapy to keep their O2 saturation up, chest tube to reestablish the pressure within the pleural cavity, and keep the head of the bed up for ease of breathing. So here you can see the pneumothorax. You can see that they put in the chest tube. It is probably, again, due to reinflation, due to collapse or air accumulation. So it is put into the chest approximately here and probably fed up into this area, probably about mid-lung, and will allow the lung to re-expand. If it persists more than 7 days with a chest tube, they may need to have surgery done to close the defect. That's especially true with folks that have blebs and those kind of things. I've heard the surgeon tell the patient, it's been like 6-7 days and it's not reinflating, and they're younger, they can't go home with a chest tube, they don't want to keep with that they would have to have a thoracotomy done to make the repair. Pleurodesis is also another option that can be done via thoracotomy or thoracentesis or via a chest tube, and we already talked about those adhesions. When it does sclerose those two linings together, it will prevent collapse. Discharge instructions for our folks. They need to avoid anything that increases pressure within the lungs, excessive activity, Valsalva maneuver, etc. When it occurs again, they'll have the repeat signs and symptoms they had when they first came in, dyspnea, etc. Okay. second type would be some type of opening in the chest wall. Again, frequently associated with bleeding and injuries to the heart or other large vessels. Nursing intervention for penetrating objects. We don't remove it. Remember, if it's in place. It could be sealing off some type of vessel, so we want to just leave it as is. And then once we've done x-rays or something to see that it is not involving some type of vasculature, then the object can be removed. So this would be some type of penetrating object, you impaled yourself, gunshot wound, surgical procedures, some type of accident, something like that could cause an open chest wound. Sucking chest wounds, you can Google those too. There's some videos on that. But if you're able to hear a air exchange out of the hole in the chest, then you would only want to put a 3-sided dressing over it until you're able to get a chest tube established. If you seal the hole completely up, air does come through the trachea out into the lungs, the bronchial tree. It escapes out into the pleural cavity, and then air gets built up and we get what we call a tension pneumothorax. So until you can get a chest tube in place, we only want to tape 3 sides so that the air can escape, and you'll actually be able to hear that air exchange. Excuse me. Don't pull the knife out, leave it in place. Our next problem is a medical emergency. It's what we call a tension pneumothorax. Air accumulates in the pleural cavity, producing increased pressure. With each inspiration, air cannot escape. So you can see air is coming out here. And if we have this sealed up with a 4-sided dressing over this hole and the air can't escape out here, then the air builds up here and it pushes the trachea over. We call it tracheal deviation. We have cardiopulmonary compromise here. It can squeeze off the heart. It can squeeze off the other lung. So it's definitely something that we need to get remedied very quickly. It can cause the heart and great vessels and trachea to deviate. You could have possible twisting of the vessels or compression of the other lung. It's caused by a decreased venous return to the heart and cardiopulmonary collapse. It causes that, I should say. Signs and symptoms for this. They have increased dyspnea, cyanosis, tachycardia, JVD, asymmetrical chest movements, decreased breath sounds unilaterally. Intervention is going to be a chest tube and oxygen therapy. So a chest tube will be put in fairly quickly by the physician. Once that is established and that air can start to relieve itself, the pneumothorax, the tension pneumothorax should start to resolve itself. So I'll tell you a quick story. We had a student of mine who was an LPN articulation student, and they were going back for their RN degree, but during the articulation piece, he developed a spontaneous pneumothorax. He was I wouldn't say a fairly tall man, but a very thin man who smoked. So he got put into the hospital at Med Central at that time, and they put a chest tube in the emergency room, and of course he had to stay for several days till it would reinflate. Well, I was bringing articulation students to the hospital on the unit that he was on. So I asked him if he cared, if one of the students cared for him, because he had a chest tube set up. And it was a good learning experience for this LPN because they had really never cared for somebody with it. Said, no problem. Well, when we first got there, he was complaining of continued shortness of breath and his O2 sats were going down. So the RN said, well, we better call and get a stat chest x-ray. Well, when they did the chest x-ray, as soon as they got back down, at this time they were still developing films. It wasn't, the computer screen where you can see what's happening right away. They had to develop the film, but as soon as they developed the film, they called right up and said, this gentleman has the developing tension pneumothorax. You need to get a hold of the surgeon. So the nurse called the surgeon. Within about 15 minutes, the surgeon was there. Unfortunately, they had put in too small of a diameter of chest tube, and it was not drawing out the air quick enough for the buildup that was happening. So they had to pull that one and put a larger diameter chest tube in. So not only did he have to have a chest tube once, but he had to have a chest tube twice. So even though he had the chest tube in place, it was not large enough to get rid of the air that was accumulating fast enough, and he actually developed a tension pneumothorax with his chest tube in place. So I guess the moral of that story is never take it for granted that just because they have a chest tube there, that complications still can occur. All right, on to the next one. Hemothorax. This is just a collection of blood in the pleural cavity. It impedes the expansion of the lung. Again, if it's pretty small, they won't do anything with it. It's kind of like having a bruise. They'll just let it reabsorb. If it's fairly large and impeding how well the lung expands, then they will need to do some type of surgical procedure to remedy it. So, types of chest surgery. This is a thoracotomy incision. You can see that it goes from the back of the scapula around to the front, and then the lower portion here is where he would have had a couple of chest tubes in place. A pneumonectomy is just a removal of an entire lung, left or right. The space fills with pleural fluid, it consolidates, they can crush the phrenic nerve, which allows the diaphragm to kind of raise up, and then the bowels will resettle and take up that new space. This is the lobectomy, the one in the middle, so we've taken the upper lobe off. So they're left with two others on the right side. Pneumonectomy, you can see that they've taken the entire lung field out. And then a segmental resection, they're just taking a segment of the lung. For the segmental resection, it's a more difficult, long, involved surgery because they're actually resecting a lobe versus just cutting the entire lobe out. And then a wedge resection is just the tissue is removed in the shape of a wedge, and it's for a localized lesion. So a very small area, maybe like a carcinoma in situ of the lung. Comparison of pain and muscular interference. Posterior lateral is the most painful. You have pictures on the back of your guide there. That was the picture that I was showing you. That was this one here. So they go through all the musculature here. They cut through that. They'll actually be spreading the ribs with retractors. They can have a lot of nerve pain because nerves run along the ribs. A lot of muscular pain. These folks have difficulty. If this is the right side, you can imagine using your right arm, trying to wipe your hiney, trying to get yourself in and out of bed, etc., to an upright position. You don't quite realize how many back muscles and stuff you utilize until you have a incision that goes along the whole side and the back of your chest, to know that you use all of those when you move, get up from a chair, etc. Oops. The anterior lateral, you can see that one. That's more anteriorly. It goes through a little less musculature, but still quite a bit, so it's quite painful. And then you have the median sternotomy. This is the least painful, especially if you support the chest area with a pillow. Again, this is more the sternotomies that they do for your open hearts, etc. And those people have discomfort, but they're up moving around pretty good in a couple of days, especially with a pillow or a bear or whatever they may have. The sternum is also wired shut, which gives some support too. And if you think of push on the center of your chest, you're not cutting through a lot of muscle. Now you are retracting ribs there, so you are going to have the rib discomfort and maybe a little bit of irritation of nerves, but not the musculature that you would have on top of it if you had the posterior lateral and the anterior lateral incisions. That should be it for this one. So let me stop sharing this. And then we should have a post-op surgical care plan that we're going to go over. Minimize that. Share your screen, Lisa. All right. So I'll give you a few minutes to find that lecture guide. It's not a real long one, and a lot of it should make common sense to you, but I want to touch on a couple of things that are a little different related to thoracic surgery. Oops. Here's what I want to do. This one. Okay, hopefully you have that out. So our first particular problem that we can have for these patients is ineffective airway clearance, and you can read it's due to all kinds of things that can occur due to surgical intervention. And really what we're looking for here is they're in pain, they have a poor cough, they've had a pneumonectomy, they're not motivated, or they're restricted in some of their positions due to their particular surgery. What are some of the possible complications then that can occur due to this? Well, it's the fact that they could have atelectasis, pneumonias. Of course, our worst of the two would be empyemas, thrombus, or just a decreased oxygenation. Our goal, obviously, was that they would have no complications and they would have an effective airway. We can have them cough and deep breathe. The frequency of it would be at least every hour. Oftentimes they'll say every hour while awake, just so if they're sleeping during the night that they're not interfered with. But if they have poor respiratory effort, instead of every 2 hours, they probably will be coming every hour until they can show that they're working pretty hard at this. Positioning for them would be splinting either the side of the chest or the front of the chest and in an upright position. Timing, oftentimes after they've given medications, we're going to talk about medications in a minute, and it tells you to watch giving large doses of narcotics. But I will tell you that when you've had a sternotomy or even that posterior or anterior lateral thoracotomies, especially the last two, you are going to need pain medication because you want them to cough and deep breathe. You want them to do activities for themselves. You want them to ambulate. And unfortunately, in order to get them to do that, they're going to have some type of narcotic on board. So timing would be, at least probably a good 30 minutes after you've given them pain medication. What do we watch for then? Watch breath sounds, watch chest expansion. We don't really deep suction after a pneumonectomy because we could be jabbing against that surgical site where that lobe has been removed, and we definitely don't want to do that. Fluids are good because it does help them liquefy secretions and get them coughed up. Remember, if fluid overload would be an issue due to a pneumonectomy, then we would want to back off of some of our fluids that the patient was taking in via IV fluids or oral consumption. And again, encourage their incentive spirometry. Like I say, respiratory will be on them every hour if they're making poor effort. If they make a good effort, then they'll probably back it off to every couple of hours. The next thing we can do is positioning for the patient. Obviously, keeping the head of the bed at that 30 to 45 degrees. 45 is pretty severe. I think 30 is probably pretty good, especially with a pillow behind them. But 45, if they need better oxygenation, can help. Changing their position at least every 2 hours. So if they're not getting up, they at least need to roll side to side and back. If we can get them up into the chair or even sit at the bedside, that would be great. That really helps with circulation and oxygenation also. activity. We want them to ambulate as soon as possible. Again, don't take them to the point where they're totally exhausted, to their doorway and back, and then maybe later on in the afternoon, they go out to the next doorway and back, etc. Oxygen therapy, this will be titrated via RT and the physician, so you might have parameters. Keep the oxygen saturation greater than 93%, so you can titrate it up and down based on what the needs are. Our second possible problem is hemorrhage. And we could be hemorrhage due to our surgical incision. And oftentimes, thoracic surgeries are one or the other. They're either highly bloody or they're not. So it's not uncommon that your thoracic patient might have to have some type of blood transfusion or so a day or two after surgery due to the amount of blood loss that they have suffered. So vital signs are a real good indicator. If we had hemorrhage, we would be like hypovolemic shock. So remember what happens in hypovolemic shock. Your pulse goes up and your blood pressure goes down. Your pulse goes up in response to your low blood pressure to try to compensate for that. So postoperatively, they will have went to a PACU for you. So by the time they get to you, they should be fairly stable. These patients will either go to a step-down unit or they'll be on your specialty unit for thoracic type surgeries. Again, monitor them fairly closely because there was a risk of a lot of bleeding during their particular surgery. Most of the time on your post-op surgeries, when they come back from PACU, especially in your larger hospitals, they should give you an estimation of blood loss, which will give you a good clue as to how you think your vital signs, urinary outputs and stuff are going to progress for you throughout the day and night. Watch for signs of shock. We kind of talked about that. They're going to have a chest tube. That lung has to be collapsed in order for the surgical intervention to take place. So they're going to put a chest tube in not only for fluid removal, but also for air removal so that that lung can reaccumulate. Watch your chest tube setups. We'll talk about those in lab next week. I'll demonstrate those for you, and I have a video that we can watch. But we don't want those devices to become overly full because it does impede how well they work. So we'll talk about that next week. We do check the chest tube setup every hour for outputs. You may have noticed that a couple of you got to tour the CVICU. One of you or two of you got to go see an open heart surgery. Those particular mediastinal chest tubes are for drainage, particularly, not necessarily for air removal. So they have larger volumes of outputs. If the chest tube is there not for drainage but air removal, you'll have some pleuritic fluid that comes down through, but it won't be large volumes like a tube that is specifically there for drainage of fluid, if that makes sense. So we have a little bit, I want you to highlight this because you do need to know when is too much. And if you're talking about a regular chest tube drainage that exceeds 70 mLs an hour or is bright red in nature, you need to call that to the doctor. Now, in your CVICU, we do expect quite a bit of volume initially. And so you will have some parameters as to when you need to call your open heart doc and what colors they're looking for and how quickly that should change. So those will be just a little bit different than our thoracic chest tubes. Blood on your dressing should be minimal. If it's seeping through, remember to reinforce the dressing and notify the physician. Our third particular problem could be congestive heart failure or hypervolemia. Congestive heart failure due to circulatory issues that may ramp themselves up due to this thoracic surgery. hypervolemia due to decreased tissue volume, but you didn't decrease blood volume. So the other lung has to get used to more volume coming through that, and that can take several days for that adjustment to take place. So we monitor for fluid overload. We're looking for pulmonary edema. We're looking for changes in vital signs for that. Pneumonectomy patients, kind of just highlighted on that a minute ago. And if you have a history of congestive heart failure, these folks are a little higher risk for this to occur. Watch your rate of fluids. You know, sometimes physicians forget, they treat them more as a surgical patient than a medical. So if you have a known congestive heart failure patient and they come back and the fluids are running like at 125 or so, you will need to watch them fairly closely. And if you notice that they have any type of crackling or increased moisture, you may need to notify the physician or cut the rates down yourself and then let them know so that you can get an official order, maybe to go to a 50 or even a KVO down to a 10 or 20 an hour. We want to monitor for jugular vein distension. That would tell you that we're having congestive heart failure or hypervolemia. We talked about rales, difficulty breathing, etc. If pulmonary edema occurs, we said slow the fluids while you get an order for that. If they end up in a surgical step down or an ICU, you may find that they have an arterial line or central venous pressure, and we're watching those changes to make sure that they don't show any type of hypervolemia. Our next particular problem for a thoracic patient might be comfort. That would be helping with that surgical incision with medications such as IV push medications, PCAs. We went through fluxes of using PCAs and then not using PCAs and then IM medications and then back to IV push medications. So it fluctuates all the time as to what the preference is. Most general surgeries do not get PCAs anymore, but if they're involved like thoracic, where you have a lot of nerve pain, those kind of things, patients are getting PCAs to control their pain. Schedule them at a regular interval, again, around activities, things that you want them to do too. Watch the effectiveness of them, watch for respiratory depression. We want them to cough and deep breathe, so making them comfortable makes that more feasible for the patient. Epidurals sometimes are utilized for irritations from nerve discomfort or retracting of the ribs can be very painful for them. My son had pectus excavatum, which is the sinking of the sternum, and so he had a metal titanium rod or bar put in his chest. So they made an incision on the left and the right side of his rib cage, put in the bar upside down, and then once they got it in there, flipped it to push the sternum outward. So when he came back to us at Nationwide, he was in the intensive care unit, but he had 2 epidurals, one feeding the right ribs, one feeding the left ribs, plus a PCA, plus Toradol, plus other pain medications. And just to the sheer painfulness of the procedure, in order for him to get up and get moving, cough and deep breathe, those kind of things, sit up in the chair, he needed all of that pain medication on board for a couple of days in order for those activities to take place. After, on the 3rd day, they kept the epidurals and the PCA, but backed off some of his other medication because I told him I thought he was a little stoned at the time and was a little maybe detrimental and could handle a little more pain than what he was. And then by the 4th day, they got rid of his epidurals, his PCA, put him on some oral medications because he was eating more and could tolerate the oral medications. And then by the 5th day, he went home with some basic narcotics and was discharged. So, but very painful. Not big incisions, only about maybe an inch on both sides of his chest, but due to the manipulation of that bar and the manipulation of the rib cage and sternum, there's where the pain came from. This is the one that is a little different than the rest of them, because the other ones you can visually see, they could occur with other surgical procedures. Subcutaneous emphysema, or air in the tissues. We often call it crepitus, but it is subcutaneous emphysema. This is like Rice Krispies popping between your fingers. It's the kind of the sound or the feel that it gives when you touch it. It is common. You do need to report the progression. I want to say it's common, but it is not normal, if that makes sense. So it is a frequently occurring thing, but it is not normal. It still should not happen. Pneumonectomy patients, that stump should be well sealed. They should not have subcu emphysema. So if you notice subcu emphysema on a pneumonectomy patient, we should report that to the physician immediately. Progression on that, your notes talk about, so if I have a chest tube over here on my right rib area where the chest tube is inserted, I'm marking it with a pen like you would cellulitis. And then if that increases, usually by a hand size, we would want to let the physician know, because if it does migrate up to the tracheal area, it can cause an airway obstruction. So it can be detrimental. Most of the times it is not. They get their initial subcutaneous emphysema during the surgery area or in the immediate post-op, and it usually does not progress. Activity. So activity intolerance, possibly due to blood loss, surgery, loss of the lung, the pain that they're in. We want to keep their oxygen on during activity. If you remember, the rule is if you need oxygen at rest, you're going to need oxygen with activity. So make sure you put your extensions on or take an O2 tank with you if you ambulate out in the hallway. We want them to move around, but not to the point of fatigue. You know, if you make them walk down the hallway 5 rooms, they've got to get back 5 rooms. So, you know, it's building up a tolerance for this. Monitor their vital signs before and after. That tells us how well they're tolerating the procedure right. We would expect that their blood pressure and pulse would go up with activity. It should come back down after the activity and within a reasonable amount of time. Within, 5 to 10 minutes, that should be back to normal. I think this is our last diagnostic. Our problem could be ankylosis of the shoulder. It's the old adage, if you don't use it, you'll lose it. So if I have surgery on my right thoracic area, my tendency will be not to want to move that right arm or shoulder because it's painful. Every time you lift up that arm, you're pulling on those muscles and it's uncomfortable. So I don't have any exercises on the back page. I should take this out. Physical therapy can work with the patient to prevent this, but what you can do as the nurse is to have them exercise that arm just a little bit. And when I mean exercise, I just mean ADLs. Have them wash their face with that right arm. Have them comb their hair. Put their bedside table on the affected side and explain why. I want you to reach for your water with that right arm. I want you to be able to stretch that shoulder out and move it. Those shoulders can actually lock up, and sometimes it takes sedation for them to actually almost free that shoulder from being tightened in that socket. So we want to make sure they keep moving. All right, that is all I have on that. Like I say, we'll do chest tubes in lab because I think it's easier if you actually see the chest tube setup. I'm going to let you take a quick 5-6 minute break. I'll pull up pituitary because I have to go use the restroom. And I will be back and we'll start on pituitary and then we'll go till about 12:30. I'll tell Mrs. Rose then if she wants to do a little bit of review with you, she can, okay? So take about a 5-minute break here. Let me run to the bathroom and get up our other screen.